Let's talk about PCOS for a little bit because we're talking so much about endometriosis, but PCO is another one of these inflammatory conditions that's out there now, probably in response to all of the sugar in the food. How do you go about working with women that have PCO?
We have very good number of patients with PCOS, and if you imagine, it's on a spectrum of things that happens. Some patients, they have severe forms, and sometimes they are in the middle. How we diagnose it is the patients, they come in with irregular cycles, irregular periods, sometimes no period for a whole year. And it is also metabolic syndrome. So if you look at their biomarkers, they might be sometimes pre-diabetic. The testosterone, male hormone, can be high. And in occasions, they're normal range, but still patients not ovulating. And when we do ultrasound, we see the characteristic of polycystic ovary. Now, if the patient is having higher BMI, we try to work on their lifestyle and their basically improving to a healthier weight, healthier diet, and as you mentioned, to decrease the inflammation, and see if we can resume their regular menstrual cycle. If they do, then they're ovulating. They really wouldn't probably need anything else than that. So first, changing the lifestyle, and then in occasions there are patients that they have healthy BMI. They don't ovulate, they don't have a period. That's when we start working with medication, and again, holistic approach to decreases the inflammation and their stress level. And one other thing that we should always consider, PCOS patients, many of them, they also have other basically psychological challenges such as depression or anxiety, that as physicians we should also address those health issues, or basically help them to get through the challenges. It does help them to be consistent with the changes, with the medications and protocols.
Right. And looking at the thyroid, maybe.
But for PCOS patients, definitely before making the diagnosis, we have to rule out thyroid issues.
Yeah.
So we cannot make the diagnosis before checking to make sure that this is not other hormonal problems. Yes.
Right. Yeah. Polycystic ovaries. It's interesting because I have some patients, I think I mostly work with the diminished ovarian reserve cases, and they have friends who their friends stimulated 30 eggs, or they retrieved 30 eggs, and that makes my patients feel somehow inadequate. But a lot of the times those 30 eggs will not amount to many normal embryos.
Yes.
Because the way that the body is releasing all of those secondary follicles, but there's at the end of the day, there's usually one or two that are the ones in nature that are rallying to be the best, right? So
this is what I always tell the patients, we need one good egg and one good sperm to get to the baby. And it's not necessarily a game of the numbers. So not necessarily having more translates to having more blastocysts or normal embryo. And one thing that we have to always reconsider, having hyperstimulation or giving high dose of medication, getting a lot of eggs, actually it works reverse. And we have to modify, and I sometimes see patients as a second opinion, third opinion. They come in, they talk about previous IVF cycles, that okay, I got stimulated, I had this many eggs, and I had no embryo to transfer. And sure enough, when we go the lower dose and the lower number of days that they were exposed to those hormones, we get maybe lower number, but definitely better quality embryos. So yes, Always, we need only one good egg and one good sperm to get to a healthy baby.
Which is a very different messaging than has been the case for IVF for the past 2 decades that I've been in the field, where it was always like, it's a numbers game and we want to get as many as we can so that we can have them. But I think coming out of the quarantine where the egg counts were dropped so drastically that the RE started to say it's quality over quantity.
Absolutely.
And
yes.
I think that that has really helped with the psyche of these patients, because to be already stressed out about going to fertility, it can be expensive. It's so many appointments. It's all the things.
Yes.
But then to have the internal messaging of not enough. I'm not enough, I'm not making enough, or whatever. But for you to remind them to say it, it really is. If they can get 1 or 2, and those have good quality because of the optimization, maybe the supplements, different food, things like the seed program,
absolutely,
then there is a good chance of those to create some normal embryos.
Let me give you an example. What we noticed that even with the donor eggs, these are females that are healthy individuals, they are in their 20s, and if we stimulate that ovary or their ovaries with high dose of medication, and let's say I have seen patients that they had stimulation getting 50 eggs, which is, to me, that's not acceptable.
Mm-hmm.
So higher dose, longer, many more days of exposure, and then when we create the embryo, very, very poor results.
Mm-hmm.
And they are not patients, these are just donors. They're helping other individuals to get to the pregnancy. So that modification is a key factor to get to success. Again, not necessarily high dose and too many eggs.
Must be interesting as the physician prescribing the protocols when you switch gears from, okay, a diminished ovarian reserve to how I'm going to stimulate a donor.
Yes. Yeah.
Right? It's 2 different parts of your brain.
Even for diminished ovarian reserve, Danica, sometimes we have patients that, they do better with natural cycle.
Yeah, even with the donors?
Yeah, not donor, not diminished ovarian reserve. Instead like, stimulating to get 2 or 3 eggs, doing no medication and just going for their own body, how their body is responding to their endogenous hormones, and just going for 1 follicle, getting 1 egg. Some of you have better results than having multiple eggs from even same patient.
Sure, because it mimics nature, right?
Yeah.
Yeah, that's so. For you to say that should be speaking to listeners who have been so hung up on the thought of, I need to get more, I need more, I need to have an extra, like a surplus. Sometimes it really is painstaking or a lot of patience required to batch, maybe like get 1 and then wait and recover and then go back in for another.
Yes. It's a process.
It's a process. Yes. All of it is a process. I'm just curious. I want to talk a little bit more about the immune system with regards to things that haven't been looked at so much since COVID. But before we hit the COVID blip on the screen, there was a lot more consideration of like ANA, anti-nucleic antibodies, and APA, MTHFR. Do you guys typically screen for that, or is it just in women with recurrent loss? So
it really depends on the circumstances. So patients come in and with history of sudden changes in the symptoms. So we are worried about any type of rheumatologic disorder, as you mentioned, like lupus, rheumatoid arthritis. Then yes, we check to see what's the level of inflammation, And in occasions, we consult the rheumatologist, the person who can help them to help with the proper medications to decrease the symptoms and help to those antibodies to go down. Now, if patients come in and has a history of recurrent pregnancy loss, then we have to look to see what is the reason for that recurrent pregnancy loss. And as you mentioned, thyroid antibody can be one. This is something that can easily get missed. In multiple cases, patients, they check just the TSH, the thyroid, but not checking the thyroid antibody. So there are patients that they have normal TSH, but that antibody is very high, and that can be fixed by giving them treatment during the cycle. So bringing the antibody level down, it helps us to get to the pregnancy. Or patients that we have no explanation, they get pregnant and keep having miscarriages. And we look at for antiphospholipid antibody, if they have the antibody, just simply we have to just give them anticoagulation during the pregnancy. So it really depends on the context when they come in. And again, we have to be very careful in terms of what testing we are ordering. And consideration should be also for patients that not necessarily insurances covers fertility evaluation. So we have to be very careful in terms of what testing we are ordering.
Right.